exciting session. Dr. Peter Feis is ready, so he's going to speak first and then followed by Thomas Platz. The topic is how to optimize physical functions in persons with multiple sclerosis. Dr. Peter Feis is from the University of Hasselt, Faculty of Rehabilitation Sciences, River Rehabilitation Research Center. Is an accomplished scientist and leader in multiple sclerosis rehabilitation with more than 245 publications and H-index of 45. Specialized, of course, in multiple sclerosis, and that's why he's giving this talk. Past Dean of the Faculty of Rehabilitation Sciences, past President of RIMS, and the work group member of the WHO World Rehabilitation Assembly, Alliance, PROMS, PMSA, and is actually co-chair of the multiple sclerosis group of the Lancet Commission on Neurorehabilitation. So welcome, Peter Feis.
Thank you. Thank you for the introduction. Thank you for the invitation to be here in Mumbai at this fantastic conference with a very dense, appealing, and a program with many, many different topics. I will talk during the coming 20-25 minutes about multiple sclerosis and about physical function, but giving the multidisciplinary perspective here present in the room, I expanded, or I focused, I would say, to early multiple sclerosis. And besides the value of exercise, I want to address a bit of fatigue and fatigability. So first, we will talk about MS as an autoimmune and neurodegenerative disease. Then I will focus on start exercise early, giving the need for neuroprotection in the brain, but also giving the high symptom prevalence. And we will see how fatigue and fatigability is challenging to engage in exercise. Most of you are very familiar with neurological conditions, and most of you maybe as well remember that MS is characterized by acute focal inflammations that can affect white matter, lead to demyelination, and reduce nerve conduction velocity. At the other hand side is also the neurodegeneration, a chronic and widespread inflammation that is leading to neurodegeneration and atrophy, cortical thinning, and axonal loss. The latter is becoming more prominent because if we translate that to the typical figures of the progression in MS, we know that the acute inflammation in red is now better controlled by disease-modifying drugs, so that many patients are not showing anymore these manifest relapses and disability increases that are very acute. So we focus much more on the chronic and widespread inflammation, so the neurodegeneration, which is in pink, and on the neural reserve in green, that is going down when there's more neurodegeneration. So in other words, the relapsing remitting type of MS is not seen that much anymore, thanks to improvements in disease-modifying drugs. So we want to protect better the brain reserve, the brain volume, and protect, if possible, the neurodegeneration. Looking to that in a simplified version, we can here see brain volume going down. Well, every human being has atrophy over time. So in a way, it is normal that with increasing age, your brain volume is going down. However, it's going faster in persons with MS. It's an accelerated neurodegeneration and loss of volume, accelerated aging, while clinical disability is going up. And the premise that we see from exercise is that if you would add exercise to persons with MS, if they will do it, that we have a scenario in green, so that the brain volume loss is lower. And thanks to the reduced brain volume loss, we have less symptom accumulation or disability. And maybe in blue, we have to already promote a lifestyle. And we know that actually for all of us, brain health from in their daily life, and especially for persons at diagnosis with MS, to even have a better outcome. And there are now studies that are showing that exercise, and in the labs, it was typically in the beginning investigated with gym-based training, so resistance training and aerobic training, very easy to quantify, to dosage, to do intensively. But we know that that is safe. It's not leading to an extra risk for relapses. It's not leading to an accumulation of fatigue. It is safe, and it may even prevent this acute inflammation at the time where medication was not yet that proficient. But we are starting to believe that exercise may also be contributing to neuroprotection, to keeping your brain volume. And this is just one illustration of a study that is meanwhile already 7 years ago published about resistance training. A long time, 24 weeks of resistance training was performed in one group, and the other group has to wait for that resistance training regime, and they were instructed to be active. So they got self-guided physical activity, which in reality, when you would say to me, you have to be more active, maybe I would not do it during these 24 weeks. If you look then to the graphs at the left-hand side, you see the difference between week 0, T0, and T24. And if you look, you see that the group that was doing progressive resistance training, and let's see if it works to show it, no, with a pointer. The PRT group is not changing in brain volume, so there is no brain volume loss at the left-hand side, but you see that there's almost a trend for brain volume loss in the waiting list control group. So the person that were not engaged in exercise had atrophy, had neurodegeneration, has a reduction of brain volume. If you look to the graph at the right side, then when persons would that were training, and let me try, oh, this is working, perfect. So the group that was doing first resistance training was now doing nothing, was getting self-guided physical activity, while the same group that protected their brain now got a reduction in brain volume. And the other group that got a reduction in brain volume by doing nothing, who was engaging now in PRT, progressive resistance training, they could protect their brain volume. So we have an indication that it might be realistic to think that there is some contribution of exercise to protect the overall brain volume. Of course, it requires a lot of training. Brain volume is, of course, a generic metric that you can also compare then with disease-modifying drugs effects. For motor function, we have to look to our tracts, of course, our motor tracts, like the cortical spinal tract, the cortico-reticular tract. We have to look also to the cortex, because we know now in MS that also the cortex is suffering from cortical thinning. That's quite recently that we are fully aware about this reduction of cortical layers. And of course, when your cortical thickness is maybe lower, then maybe your use of your cortex is more problematic. When you want to increase oxygen consumption, when you want to compensate in your brain, it's good that you have like sufficient cortex to be able to do that and to connect with other cortical and subcortical regions. So there's a risk that could be affected. So it's important that also exercise would have effects on the thickness of our cortex. And in general, we have now a accumulation of evidence that also in MS, it is possible when you are doing interventions, exercise training, but also action observation, balance training, cognitive rehabilitation, and computerized training, that we can impact on some structures, on the integrity of tracts, and on functional neuroplasticity. So it's worth embarking in intensive exercise, especially in the beginning. Another reason why exercise is needed and should be advocated and instructed, educated in the beginning is that there is a high prevalence of symptoms already at onset of multiple sclerosis. There was a survey in Europe where 17,000 people have responded in different countries with a different disease duration, and they were being asked, are you perceiving symptoms in your daily life? And these are type of graphs that will be published on a multiple sclerosis journal. So if you look to this, and I first want to go actually to the right, we see that on average per respondent, there is an average of 13.7 symptoms that are being perceived by persons with MS, which is really quite a lot. We know this heterogeneity in the clinical picture, but 13 is a high number. And this number was already present in those people that only got a diagnosis in the last 5 years. It's going a little bit higher when people are having maybe 15 years of diagnosis, but then still it's maybe 14.8. So it's going up a little bit, but not that much. So symptoms are being present and perceived already in the first years after diagnosis. If you are looking to the top ones, well, we are not surprised for MS that fatigue is number one. It's a consistent finding that we see in this pathology. But of course, also invisible symptoms like cognitive impairment is there. Pain is being reported. Sensory problems are being reported, and sleep disturbances. When you look to the blue arrows, we see the motor impairments that are being reported. Mobility is present, of course, and spasticity, but actually even more prevalent reported is balance problems. So I have been learning that indeed in the early phase of MS, balance is already being perceived as different in persons with MS, maybe before they are reporting that mobility is being affected. So early balance training will be a recommendation that we are advocating. When we go to impact, the storyline is the same for the invisible problems like fatigue and cognition. It's a bit different for the motor symptoms there than the impact of perceiving a mobility problem is greater than perceiving a balance problem. However, balance is also still in the top number 5. This is a report of patients. However, we can also test our patients. This is an interesting data set from Denmark that is recently published in 84 people with MS having a diagnosis not longer than 2 years. We can test them, and typically we have standard tests that are being applied in research, which are short walking tests, like the time 25-foot walk is 7.6 meters, and the PASSAT or symbol digit modality test for cognition, short test of 90 up to 180 seconds. These are typically the benchmarks also in medical trials to measure success. But we may be missing in the early phase already these functions that are present and that are larger and more prevalent than these standard tests. We are referring to tests like the 6-spot step test, which is a test to walk and to kick cones. So you have to go somewhere. You have to make a movement with your leg. You have to kick a cone, so you need balance as well and turns to make this activity. Aerobic fitness is already impaired in these early MS patients, so their fitness is clearly already lower than healthy controls. And the same for daily physical activity, which we can, of course, measure easily with technology nowadays. So it is reality, and therefore, indeed, we are advocating exercise instructions to patients and family members already at a very early stage. And we know it is an effective method in early stage, but also at moderate disability, and to some extent for those with more walking with a stick or needing assistive devices to walk. Effects are a bit lower when there is more brain degeneration. Effects can be found, and we know that nowadays that there is better aerobic capacity, muscle strength, better balance, better walking function. However, we are a bit unsure about cognitive function, whether exercise is impacting as well cognition. That's still more a question mark at the moment. For the therapist in the room, or maybe also actually for every doctor, it's also important to be aware that if we talk about balance training, that it looks very simple, but it's really much more than just standing on one leg. It's really an analysis that you have to make about the problems in reactive and proactive controls. And there are different strategies to challenge your balance. And for those who want to know more, there's a very interesting clinical-oriented paper being published by Brinks from Denmark in 2023. You also see that nowadays at left-hand side, you would also include, for example, cognitive motor challenges, because that is what we do in daily life. So not just standing on the leg, but giving a lot of challenges in the cognitive domain. And also a question we got yesterday at the right-hand side, there is a value of virtual reality training here and extra gaming in improving your balance. So exercise, we talked about gym-based training, about balance training, and we have also the awareness that cheap interventions as just walking training are also as effective perhaps than the other types of training modalities. One thing, however, that is coming back in the exercise is it's not just walking. We have to define and prescribe intensity so that they are walking, but their heart rate is going up, that they are playing around with different speeds and engagement, attention, executive controls, that we are trying to engage also aerobic capacities, submaximal capacities, And we can do variations also during our walking with technology in virtual gaming environments, with dual tasking, and we can play around with types of continuous compared to intermittent training. Having said that, we also are aware that there are more and more studies also for improving balance, for example, of other modalities like yoga or Tai Chi. We have the power of music and dance also witnessed yesterday during the opening ceremony, and other type of interventions that has been promoted. Of course, I talk now about physical function in a very generic perspective. We are knowing that there is spasticity occurring, there is muscle weakness, there is incoordination that can happen. In the beginning, especially, we have to focus on the ankle function as one of the first areas that we see changes in over time. It has to be analyzed with an experienced clinical eye or using instrumented type of metrics. But we know that also these gait parameters, they can be influenced. And that is what has to be incorporated in our training, the attention to specific joints, the attention to antagonist and agonist muscles in which have more muscle weakness or spasticity, and attention to the performance. In people with early MS, with mild disability, it is possible to still have attention and having the brain correcting the type of movements. Independent of your gait pattern dysfunction, the translation should be, of course, also to daily life. We all know that we have to move, and we have instructions from WHO, the World Health Organization, to move. We should be moving intensively for 300 minutes a week. Optimally, we combine some resistance elements, strength elements with endurance components. And that has actually been a challenge so far, also in MS, to really show that you are able to increase physical activity, and both in quantity, in number of steps, but also in intensity. And there are actually few studies, maybe to your surprise and my surprise, that have demonstrated effectiveness to increase this physical activity component. So for those interested, I refer here to a study from the United States that is recently published, a STEP for MS study, but where you see it's not just giving a pedometer or an accelerometer or a smartphone app, but it's really tailoring aerobic components, resistance training components with cheap materials like elastic bands to the patients, giving detailed training schemes, do monitoring, give information, have some coaching, bringing the patient in contact with peers, and having possibilities to call someone in case of difficulties. So help them with action planning, monitoring, and doing all kinds of logs. And this study then, this RCT, could demonstrate that steps per day, but also intensity of the movement, which is important for health and brain function, to have intensity of your movement in daily life to increase that. I'm risking a little bit to have a too positive story, where, well, you may know many persons with MS that are struggling, because it's not easy to be active all the time, and there is a disease that can be very affecting on health, and that is not that easy to modify or to implement. So I want actually to focus a bit more on fatigue perception, but also the concept of fatigability. So if you think about it, walking is also much more than just walking speed or just moving your muscles. You are walking with a purpose. You are walking in an environment, in a context. And when you're feeling fatigued, or you think you will feel fatigued when you're engaging in a physical activity and in a mobility performance, well, it will likely make you walk less and avoiding many of these activities. And persons with MS do report, even during walking, these kind of mental fatigue and fatigability concepts. The MS walking scale is a very short scale of 12 questions, and now more and more used in clinical practice and research. 12 questions about how MS is impacting different components related to walking. And if you look to the list, it's going from standing to running, to stair walking, to regular walking. But it's also asking about the concentration people need to walk. If your balance is impaired, if you have a bit of a drop foot, it will take you more concentration. It may take you more effort, perceived effort to walk. As I said, it may reduce your walking distance, which is more your fatigability, etc. So we are coming a little bit into the domain now of fatigue and fatigability. There are publications since 7 years and longer, also now in Nature and Nature Reviews, in MS, but also in across neurological conditions. There was a paper just last year from Iris Penner, who is also the author of this scheme. It's a bit a complex scheme for today to explain within this context, but the main thing I want to say that they are differentiating fatigue in the motor and the cognitive domain, and they have all kind of explanations peripherally, centrally, behaviorally, psychologically, and homeostasis that can explain that. If we now just zoom into fatigue at the right side, it's a subjective experience of being fatigued, having a lack of energy. We can ask about it with a simple question. We can ask about it with questionnaires. And we can realize that sometimes we can explain fatigue due to factors. So we can have secondary fatigue, which is actually here the right side I want to start with. So indeed, patient may be fatigued like all of us if we don't sleep well, but maybe they don't sleep well due to pain or spasticity. There may be depression and mood changes because there's a lot of anxiety and depression also in the beginning of the diagnosis. There is inactivity and deconditioning that can impact on your energy levels. There may be some side effects also of disease-modifying therapy or symptomatic treatments. But it can also be directly related to fatigue to the primary cause, the inflammation and the neurodegeneration pathology of MS, affecting some cytokine productions and effects on the limbic system, so mood and anxiety and change in energy. Or it is the neurodegeneration, the neural loss, the synaptic degeneration, which makes that people have to compensate in the brain by using more areas. If they are able to do so, if the cortex is thick enough to be able to compensate. But this increased brain activation can also lead to feeling fatigued all the time. So it's also important that we improve and optimize physical function, that the areas that you need to do this physical function are again more compact and not so much compensating and widespread. So what to do about fatigue? There are different interventions. And of course, I want to acknowledge first a very powerful intervention that is being delivered by the multidisciplinary team and perhaps also importantly by occupational therapists and neuropsychologists officially, which is cognitive behavioral therapy. You have to change your mindset, how fatigue is interfering with your life, that you are not always thinking about fatigue or let fatigue rule what you are doing. But there may also be a bit of energy conservation to pace your activities and to judge what you can do in a certain day, especially because fatigability may also be occurred, which will be my last slides coming up soon. And giving information, but besides of that, if you are deconditioned, exercise is of course a very important component. And given that this conference is also about telesolutions, I added this slide about the Elevida app that was developed in Germany. And is incorporating many of these components about cognitive behavioral changes, about CBT techniques, energy management, behavioral activation, exercise advices, educational modules to change the mindsets. It's actually quite efficient because the government, the health insurance system in Germany, is paying back these apps, so doctors can prescribe this app as a kind of an intervention for 3 months. And the same for depression interventions, deprexis that are being present. And that's a game changer also in Europe, that the government would engage in these type of solutions in the reimbursement schedule. If you want to know more, there's a recent paper now with the English version of this app being published in the International Journal of MS Care. But going back to optimize physical function, then I go back to the exercise, and then there has been also reflection how it come that exercise may also affect fatigue. Well, there are 2 routes that were described in the scheme from Ulrich Dalgas. That is, at the one hand side, at the bottom, that you're working on these factors that are causing maybe fatigue. So you're improving your sleep, you're trying to have a better mood, lower depression, a better cardiovascular fitness, and a better way of walking and improved motor function so that your energy cost of walking is reduced. If you walk more efficiently, you also will lose less energy and you will not contribute that much to fatigue perceptions. But you may also think, it's a hypothesis, that also the pathology is being impacted by a decrease of neurodegeneration, so a better structural function and functional system use, reduced inflammation perhaps, and changes in your HPH axis. And let's now move to the left side of this publication of Iris Penner, which is then fatigability, and that is now called the objective fatigue. It's maybe a bit strange because fatigue and fatigability are related, but correlations are only 0.3, so very low correlations. And objective fatigability would mean that we try to measure a performance. People have to do something in the cognitive domain or in the motor domain, and we try to measure then to which extent people can sustain their concentration, can sustain their motor function. For the topic today, we will be talking about muscle strength and walking. And we can measure that with all kinds of equipments and for all kinds of muscles. So at the left-hand side, you see an example maybe of a hand grip strength. So you can use a jamar or you can use it instrumentally. Typically, we ask for hand grip strength to squeeze for 3 seconds, 5 seconds, like the maximal strength. But here we are asking them to do a 30-second contractions isometrically. So typically, they're reaching their maximum, and then the strength is going down. And you can calculate the percentage that you're losing, because optimally, you can keep your maximal strength for 30 seconds. It's not reality, of course. I cannot do that. Nobody can keep the strength for 30 seconds. However, the decline is likely larger. Well, it is larger, more than 30% in persons with MS compared to healthy controls. At the right-hand side, you see this kind of sketchy figure where people are doing contractions, now concentric. For example, a quadriceps contraction. And typically, you're comparing your muscle strength at the beginning with your muscle strength at the end of these repeated contractions. Whether you're doing it 15 times or 30 times, it doesn't matter. You're looking to the decline of your MS patients compared to healthy controls. If we then look to results, we know there's a reduction. Concentrically, it was in that study like 30%, which is quite a lot. And isometrically, even here, like 57%, these are just percentages, but typically it's even a bit more during maximal isometric strength contractions. It is related likely to the central brain. It's related to your cortex, your cortical activation, your central drive, your capacity to continue programming and executing these motor programs. It may also be related to your spinal excitability. If you go to walking, we also started to investigate this fatigability during walking, because that's something clinicians see in their patients, and patients are reporting often. And there are different methodologies that you can be using. It has also been used, by the way, in rheumatoid arthritis or in myasthenia gravis, or it is, I think, also relevant even in stroke, where we have also pilot data now on trying to see if fatigability is occurring during, for example, a 3 or a 6 minutes walking test. So how do we measure that? Well, people have to walk. In the labs, we are doing typical 6 minutes. You have like 25 meters and they are making turns during 6 minutes. And we are recording the number of meters people are doing each single minute. So we are measuring performance and the fatigability over time. And if you look on average, you could say, okay, health controls, the first 2 minutes you go down a bit, and then you are stable, and then the examiner is saying, oh, minute 5, and you're thinking, oh, I'm still feeling good. I can do a bit more, so you're going up a little bit. We call it a U-shape. So at the end, you can go a little bit up. People with mild disability due to MS, they go down and they are rather stable. And people with severe disability, they show a decline minute by minute by minute up to minute 6. These are averages, and we are wondering, can we quantify that and try to talk about prevalence? Because we think that fatigability is not present in all. It's kind of a symptom that some people have more than maybe other people would have. So we were looking into the literature to all kinds of formulas, and we decided to go for the most simplistic clinical formula that can be used also in the clinical practice. And that would be just looking at the distance in your last minute compared to the distance in your first minute, divided by your distance in your first minute and by 100%. And we know that health controls would never go down more than 10%. So that was our cutoff. We were completely sure that if a person has more than 10% decline in the last compared to the first minute, that is different than you would see in health controls. If we then look to prevalences, and the layout of this slide is maybe not perfect of this figure, But on average, if you take all patients together, we would say that 43% are showing fatigability. If they have a 10% decline or more, then on average, they were declining 23% or even, 23%. And you see the pattern very clearly. It's not that they don't want to walk fast. They cannot walk fast, and they are going down and down and down all the time. Whereas others not having this criterion of 10%, they are staying more or less the same. If you look then more to the EDSS categories, which means basically disability. So 0 to 2.5 is almost no disability in the motor domain regarding just muscle contractions. There, 20% would have fatigability. It's not that much, but it's still 1 out of 5, which is maybe a lot. If you think about precision rehab and precision medicine, that 1 of 5 has already this phenomenon. If you go to people who are using a stick or a rollator, then you are having percentages of 50 to 60%, and your decline is going up to 34%, whereas in the mild early MS phase, it's going to minus 15%. Okay. So we have been talking about the most simple metric in the clinic that we think is useful to identify people at risk. We think it's important because also in medical treatment, it has been suggested that people who are showing fatigability, and we look now to the right, there's no U-curve, it's going down quite substantially, that every consequent visit during 2 years, the shape remains the same, but that their distance is going down and down, that their speed is lower at every consecutive visit. So it may be a marker to identify risk for progression compared to people who are showing a normal U-shape. Good, and for the final half a minute, I also wanted to say we can also measure with technology the gait quality, the gait pattern, how people are walking. And that's actually the next step. That is getting easier now with commercial equipments or with cheap wearable or smart engineers. And we also there have been defining cutoff scores for normality in your ankle, like your foot drop, your toe off ankle, or for your step duration variability that is also reflecting your brain control, or for other type of markers. Again, if we are making statistics, we can identify people at risk who are showing increases in step duration and variability, or who are showing changes in your toe off ankle, reflecting changes in your ankle or in your knee. Are there solutions? Very quickly, well, maybe for fatigue and fatigability, HIIT training could be solutions. In early MS, high intensity trainings, because you're doing much shorter intervals at higher heart rates and you're reaching similar effects on aerobic fitness. Intermittent training may be also solutions because people don't feel so much effort that is being performed, and they are able to do their stimulus, their training stimulus, thanks to walking intermittent instead of continuously. And we think that we have to make combinations in personalized perspective, who is needing balance trainings, movement functions training, agility training, combined with intermittent walking. There's very few research still there, and I'm so very happy that we have now many countries in the world that can contribute all together to investigate this in the largest sample. So with that, my time is up, and I thank you for your attention. I hope I convinced you that neuroprotection is important, exercising early is important, that there are many symptoms being perceived already at the early stage, that fatigue is, however, a challenge, but also fatigability is interfering, and it may be that we don't know what is the potential of training effects in those people showing this new symptom of fatigability. Thank you.
Thank you so much. I don't think we have time for questions. I think we need to take the next.
Okay, so we carry on, and it's my delicate pleasure to introduce the next speaker, who probably needs no introduction at all.